Hello, my name is Joseph Owen, and in this screencast, we will be reviewing a standard search pattern for chest CT. When I start reviewing a chest CT, I tend to start in a standard soft tissue window. In this case, my window is 315 and my level is 45. I start up at the top of the study, and I will often first look at the thyroid gland for any nodules, masses, or enlargement. After I've looked at the thyroid gland, I'm then going to look along the neck, and particularly along the jugular and carotid vessels for any lymphadenopathy. I'm going to look in the supraclavicular region for any evidence of lymph node enlargement. I'm then going to proceed into the upper mediastinum, looking for any evidence of lymphadenopathy or any mediastinal mass. This is a relatively young patient, and so in this case, they do have some residual soft tissue in the anterior mediastinum, which is normal thymus. Thymus should not be expected in an older individual. I'm then going to proceed more inferiorly into the mediastinum, looking along the trachea for any high or low paratracheal lymph nodes, any subcarinal lymphadenopathy, and then any hilar lymphadenopathy. Seeing no lymphadenopathy in the mediastinum, I will also look along the internal mammary vessels for any evidence of adenopathy, coming all the way down to the abdomen. From there, I'm going to look in the middle mediastinum, around the esophagus, for any paraesophageal adenopathy, and at the same time assessing the esophagus for caliber and wall thickness. I then will proceed to look in the axilla for any subpectoral or axillary adenopathy on the right and left side, scrolling back and forth. Having seen no adenopathy, I will now turn my attention to the heart. I like to soften the window just a little bit, and with that softer window, you can see the valves in the heart, and you get better differentiation within the vessels. I'm going to proceed up looking at the aortic arch for any enlargement, any dissection, any acute traumatic injury. I'm going to follow the thoracic aorta inferiorly down into the abdomen, looking at any vessels that happen to be in my field of view within the abdomen. I'm then going to come up and I'm going to look at the great vessels for any signs of stenosis or occlusion. I'm going to look at the vertebral arteries, and seeing no abnormality, I'm going to turn my attention to the pulmonary arteries. I'm going to look at the pulmonary arteries for any evidence of pulmonary embolus. This is very important, even on a standard chest CT with contrast, as you often, with modern scanner technology, get nice opacification of your pulmonary arteries. And incidental PE is quite common, particularly in patients with cancer. Seeing no abnormality, I will look at the aortic root, the aortic valve for any evidence of valvular calcifications. I will look along the expected courses of the coronary arteries for any evidence of atherosclerosis. I'll assess the thickness of the left ventricle, the interventricular septum, and the size of the right and left ventricle and right and left atria. Seeing no abnormality of the cardiovascular system, I will often then proceed to assess the airways in the lung. I will use a lung window for that assessment. In this case, my lung window is 1500 and minus 550. So 1500 window and a negative 550 level. I'm going to start at the apex in one lung. In this case, I see a little bit of pleuroparenchymal scar in this apex, but otherwise normal, and that's a very common finding. As I proceed inferiorly, I will look at the anterior left lung for any nodules, any airspace disease, any septal thickening, any ground glass opacity. I'll follow that all the way down into the lingula. I'll then focus my attention on the posterior half of the left chest, coming back up, again, looking for any airspace opacification, nodules, septal line thickening, pleural scarring. Don't see any. I'll then follow along the fissure, looking for any fissural nodules or fluid or thickening or calcification. And seeing none, I will then proceed to the right lung. Again, I'll start at the right apex. I'll move inferiorly, focusing on the anterior portion of the right hemithorax, all the way down into the right middle lobe. Then I'll turn my attention to the posterior right hemithorax, again, looking for any abnormalities within the lung. I then will turn my attention to the airway, looking at the trachea, the main stem bronchi, and the segmental bronchi, looking for any filling defects, bronchial wall thickening or occlusion, nodules or masses. Seeing that the airways are patent, I will then focus a little bit more on the pleura, looking along the pleural surface for any plaques, any scar, any architectural distortion or tethering. Seeing none, I will then turn my attention to the bones. I typically will start by looking at the shoulders, making sure the glenohumeral joints are in anatomic alignment. There's no evidence of severe arthritis or fracture. I then look at the clavicles, look at their orientation to the manubrium. I will then follow the spine inferiorly, looking for any abnormalities, lytic lesions, sclerotic lesions, any fractures. I will then look toward the ribs. And I think as the ribs are scrolling obliquely through your field of view, it can be challenging to keep an appropriate level of attention on any individual rib. But I will scroll back and forth through the ribs, often looking sort of generally at the posterior third of the ribs, and then the lateral ribs, and then the anterior ribs. Don't forget to look at the costochondral cartilage, which can also be impacted by fractures. I'll then move to the left side, again looking at the posterior portions of the ribs, the lateral portions of the ribs, and the anterior portions of the ribs, including the costochondral cartilage. I'm then going to look at the sternum, starting with the manubrium, moving inferiorly to the xiphoid process. Having done that, I will then often go to a sagittal. I think it is absolutely essential that you assess the spine on every body CT case in sagittal. It's very easy to miss things in the axial dimension. So I'm going to look at the spine, I'm looking at alignment, looking at the facet joints for alignment, looking for any fractures or any lytic or sclerotic lesions. I'm also going to reassess the sternum, the clavicles, the scapula, glenohumeral joints on both sides. I then will put it into a soft tissue window where I can look at the spinal canal, making sure I don't see any abnormalities within the spinal canal. I will then turn my attention to the ribs. I often find that seeing lytic or sclerotic lesions or fractures is actually easier in the sagittal and coronal plane than it is in the axial plane. So I'll slowly scroll back and forth, assessing the ribs for any evidence of abnormality. Next, I will turn to my coronal images. And again, this time focusing mostly on the ribs. You can get a nice view of all your costochondral cartilage and your sternum. And with the ribs on FOSS, oftentimes sclerotic or lytic lesions or fractures will kind of pop out at you as an abnormality as you scroll back and forth. The coronal is also a nice way to look at the pedicles of the spine for symmetry, any enlargement, abnormality, fracture. Seeing none, I will go back to my standard axial images in a soft tissue window, and I will go down and turn my attention to the abdomen. I'm going to look at the liver, the portal vein, the common bile duct, the pancreas, the spleen, the adrenal glands, the kidneys, the stomach, the gastroesophageal junction, and any other bowel that's within my field of view. I'm going to look again at the vessels to make sure I didn't overlook some abnormality. In this case, the person does have an interesting variant, which is a retroaortic left renal vein. I'll also focus my attention back on the spinal canal. Don't want to miss something in that central canal that can be life-threatening or urgent. Okay. And last but not least, I'm going to turn my attention to the chest wall. I'm going to look at the muscles of the chest, the muscles of the shoulder, looking for any asymmetry, any masses, any atrophy, the paraspinal muscles, look nice and symmetric. And then I will look at the breast tissue. So we can see this is a male. He does have some glandular breast tissue there, making sure there's no calcifications, masses, cysts, or nodules that might warrant additional follow-up. And with that, I'm confident that I have thoroughly reviewed this chest CT, and there is no abnormality, so no acute intrathoracic or cardiovascular abnormality. I hope you found this tutorial helpful. I want to reinforce the idea of a systematic search and the importance of approaching every case in a thorough, systematic way so that you're able to identify all of the abnormalities and that you don't fall prey to systematic search. To satisfaction of search, where you identify an abnormality and that distracts you and prevents you from completing your thorough systematic search of the study, and thereby causing you to miss other findings that may be present. Again, thank you for your attention, and I hope you'll review my other screencasts on CT search patterns.